Hello ladies and gentlemen, this is Dr. Helge Alexy from the Cardiology Forum, and today I welcome you to another video where I want to show you some STEMI cases, some ST elevation myocardial infarction cases, where you will see for the most of you, well-known ECG patterns of the ST elevation infarction, but in all these cases there are some specialties and some hints in these ECG patterns that make them very special, and that's worth having a look upon and discuss about that. So let's get right to it. I call this video STEMI Pearls. It's part 1. I have some more cases that I wanted to show you, but I split it up in part 1 and part 2. Part 2 will come in a couple of weeks, and this is the part 1 of the STEMI Pearls. The first case I want to show you is an ECG pattern you all are very used to. You have some ST elevation in the inferior limb leads, in lead 3 and lead AVF, so you all might think about an inferior myocardial infarction, but as well as in V1. There is an ST elevation in V1. So if you have this pattern, significant ST elevation in 3 AVF, so this might be RCA, and then V1. How do we explain the ST elevation in V1? In the contrary, you have some ST depressions in 1 AVL and the anterior chest wall leads V2 till V6. And if you have this ECG pattern, you always should think about what is causing this V1 ST elevation. Because if we refresh our memory and think about what is V1 encoding for, then we see the vector towards V1 is a vector that is encoding for the right ventricle and the basal part of the septum. And that is very important information, because a myocardial infarction that is involving the inferior parts of the LV, but also the right ventricle, very different to manage from LV myocardial infarctions alone. Because if you have involvement of the right ventricle, the patient is very much fluid dependent. If we have patients with left ventricular myocardial infarctions, you would be very restrictive with giving them fluids. That is very different to the patients that have a right ventricular myocardial infarction as well, because they are very fluid dependent. They need a high preload. And that is important, because the only way to compensate the less contracting right ventricle is giving them a huge amount of preload that supplies the left ventricle with enough blood to generate a high stroke volume. Another reason why this is important is that patients with involvement of the right ventricle are much more likely to develop severe bradycardia and maybe in need of a pacemaker implantation. So this is important information. If you have a pattern with a ST elevation in the inferior leads and V1, you might think about the involvement of the right ventricle and or the basal septum. And this is what we found. We found acute occluded right coronary artery on the proximal to medial part, and you see no RV branches going before that to the right ventricle. After having revascularized this vessel after the PCI, you can see a very big RCA and also 2 RV branches, 2 or 3 RV branches that supply the right ventricle, and that is the cause of the V1 ST elevation, as well as this big RPD that is also supplying and encoding for the basal part of the septum. What brings us to the second case. In this case, you have much more subtle ECG patterns than we had before. And this ECG, you have a discrete ST elevation of about 0.05, 0.1 millivolts in lead 2, as well as lead AVF, but very subtle. If you call this STEMI already with this pattern, it's more than 0.05. And the chest wall lead V6. This is hard to call STEMI from here, but it's not a normal ECG, especially if you look at the ST depressions here in the chest wall leads. And if you have this pattern, the ST depressions here in the chest wall leads, as well as positive T waves in V2 and V3. You don't have to have actually these ST elevations here in the posterior leads, but if you have only this pattern here, ST depressions in the anterior chest wall leads, especially V2 and V3, and a positive T wave there, then you might think about a posterior myocardial infarction. And the myocardial infarctions of the posterior wall, or the posterior segment of the left ventricle, are very much a blind spot of the 12-lead ECG we normally have. So what you want to do is having some more leads that encode for the posterior wall. And you all are aware of what we can do there. What we can do is placing some more leads that encoding and show us the posterior part of the left ventricle. And what I mean is getting some more leads on the back of the patient. And what we normally do is taking lead V4, V5 and V6 and placing them on the back under the scapula to the spine as V7, V8 and V9. And if you do that, you should mark that on the ECG strip you have then as well, so that everybody after you who gets hold of this ECG is knowing what you were doing. And this is not the normal V4, V5 and V6, but is V7, V8, V9 and encoding for the posterior wall. And if you do so, there are different thresholds you are normally used to if to call it STEMI, to give the patient the diagnosis ST elevation myocardial infarction. And this is 0.05 millivolts already. So this is what we did there. We placed the V4, V5 and V6 to V7, V8, V9. I marked it here to make that clear. And we have a very significant ST elevation in the posterior wall leads. It's more than 0.05, it's 0.1 millivolts and more that are shown in these leads. That gives the diagnosis of a posterior wall myocardial infarction is STEMI. And this is important because if you don't have these leads here, you would call that maybe some ST depressions here in the anterior chest wall leads. We will wait till the troponin shows us what is going on. But if you do these leads very quickly in the emergency department, in the emergency room, you will have a very fast diagnosis of STEMI there, and you can save precious time getting the patient quickly to the cath lab. And this is what we found in this patient. We found an acute LCX occlusion here. And this is exactly what I was talking about. The posterior part of the left ventricle is normally not displayed in our normal 12-lead ECG. Always think about, if you have this pattern, to place some more leads V7, V8 and V9. So this brings us to the end of the current video and the first part of the STEMI pearls. Thank you for your attention. Thank you for attending this video. I hope you liked it. You got maybe some information from it. If you did so, give me some feedback in the comment section. Especially important is that you had fun with this video, and the second part will come in a couple of weeks, I think. If you like this channel and if you like these kind of videos, give us your thumbs up and subscribe to the channel. I would be very grateful for that. So Have a nice day or a nice evening. Thanks for watching. Yours, Dr. Helge Alexy. Bye bye.